This is Justine Spargo, recording Chapter 18, Anxiety, Obsessive-Compulsive, and Related Disorders. Anxiety is a feeling of discomfort, apprehension, or dread related to anticipation of danger, the source of which is often nonspecific or unknown. Anxiety is considered a disorder or pathological when fears and anxieties are excessive in the cultural context, and there are associated behavioral disturbances such as interference with social and occupational functioning. Let's discuss the difference between anxiety, stress, and fear. Individuals face anxiety on a daily basis. Stress, or more prominently, a stressor, is an external pressure that is brought to bear on the individual. Anxiety is a subjective emotional response to that stressor. Anxiety may be distinguished from fear in that the former is an emotional process, whereas fear is a cognitive one. Fear involves the intellectual appraisal of a threatening stimulus. Anxiety involves the emotional response to that appraisal. Anxiety was not clearly defined or isolated as a separate entity until the 19th and 20th century. What we now know as anxiety was once only identified by its physiological symptoms, focusing largely on the cardiovascular system. Freud first introduced the term anxiety and neurosis in 1895. This notion attempted to disprove the previous concept of the problem as strictly physical, although it was some time before physicians of internal medicine were ready to accept the psychological implications for the symptoms. Researchers have begun to focus the interrelatedness of mind and body, and anxiety disorders provided an excellent example of this complex relationship. It is likely that various factors, including genetic, developmental, environmental, and psychological, play a role in the etiology of anxiety disorders. Epidemiological statistics of anxiety disorders. Anxiety disorders are the most common of all psychiatric illnesses and result in considerable functional impairment and distress. Statistics vary widely, but most agree that anxiety disorders are more common in women than in men by at least 2 to 1. Prevalence rates for anxiety disorders within the general population have been given at 3 to 5% of generalized anxiety disorder and panic disorder, 13% of social anxiety disorder, and 25% of phobias. Obsessive compulsive disorders account for 2 to 3%. Common comorbidities include another anxiety disorder, depression, and substance abuse. What's the criteria for abnormal or pathological anxiety? It's difficult to differentiate between normal and abnormal anxiety, as normal is determined by a society's standards. However, anxiety becomes generally considered abnormal or pathological if it is out of proportion to the situation that it's created, that basically anything that it's created by, or it interferes with social, occupational, or other areas of functioning. For example, if I try to put a dollar bill into a vending machine and the machine won't work or won't take it, if I get so stressed I start having a panic attack over it, that would be considered abnormal. You'd probably look at me like I'm crazy. It's clear that when anxiety becomes excessive and persistent, humans respond in a variety of ways that are likely a complex interaction of genetic vulnerability, biochemical influences, and environmental factors. Panic disorder is characterized by recurrent panic attacks, the onset of which is unpredictable and manifested by intense apprehension, fear, or terror, often associated with feelings of impending doom and accompanied by intense physical discomfort. The physical sensations can be so intense that the individual believes they're having a heart attack or other critical illness. The symptoms come on suddenly and unexpectedly. The role of organic factors in the etiology has been ruled out. The Diagnostics and Statistical Manual of Mental Disorders, 5th edition, or DSM-5, states that at least 4 of the following symptoms must be present to identify the presence of a panic attack. palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heart sensations or heat sensations, paresthesias, numbness or tingling sensations, derealization, feeling of unreality or depersonalization, feeling of being detached from oneself, fear of losing control or going crazy, and fear of dying. The attacks usually last minutes or more rarely hours. The individual often experiences varying degrees of nervousness and apprehension between attacks, and symptoms of depression are common. Generalized anxiety disorder, also known as GAD, is characterized by persistent, unrealistic, or excessive anxiety and worry, which have occurred more days than not for at least 6 months and cannot be attributed to a specific organic factor such as caffeine intoxication or hyperthyroidism. The anxiety and worry are associated with muscle tension, restlessness, or feeling keyed up or on edge. The symptoms in generalized anxiety disorder are intense enough to cause clinical significance, impairment in social, occupational, and other important areas of functioning. The individual often avoids activities or events that may result in negative outcomes or spends considerable time and effort preparing for such activities. Anxiety and worry often result in procrastination in behavior or decision making, and the individual repeatedly seeks reassurance from others. There are several theories on predisposing factors of panic and generalized anxiety disorder. The psychodynamic view of anxiety disorders focuses on the inability of the ego to intervene when conflict occurs between the ID and the superego, producing anxiety. For various reasons, ego development is delayed. When development deficits in ego functions compromise the capacity to modulate anxiety, the individual resorts to unconscious mechanisms to resolve the conflict. The main thesis of cognitive view is that faulty, distorted, or counterproductive thinking patterns accompany or go before maladaptive behaviors and emotional disorders. When there is a disturbance in the central mechanism of cognition, there is a resultant disturbance in feeling and behavior. Genetic vulnerability to panic disorders has been supported by family and twin studies. The rate for identical twins is 30%, and the risk for the disorder in close relatives is 10 to 20%. Structural brain imaging studies in patients with panic disorder have implicated pathological involvement. Abnormal elevations of blood lactate have been noted in clients with panic disorder. Also, infusion of sodium lactate into clients with anxiety neurosis produces symptoms of panic disorder. Stronger evidence exists for the involvement of the neurotransmitter norepinephrine in the etiology of panic disorder. Norepinephrine is known to mediate arousal, and it causes hyperarousal and anxiety. This fact has been demonstrated by notable increase in anxiety following the administration of drugs that increase the synaptic availability of norepinephrine. The neurotransmitter serotonin and GABA are thought to be decreased in anxiety disorders. Phobias. A phobia is a persistent, intensely felt, and irrational fear of a specific object, activity, or situation that results in a compelling desire to avoid the feared stimulus. Agoraphobia is a fear that some patients have of being open in open shops or markets, although it may be more related to fears of being vulnerable and in a less secure environment. The individual experiences fear of being in a place or situation from which to escape might be difficult, or in which help might not be available in the event that panic symptoms occur. Impairment can be severe. In extreme cases, the individual is unable to leave his or her home without being accompanied by a friend or a relative. Social anxiety disorder is an excessive fear of a situation in which a person might do something embarrassing or be evaluated negatively by others. The individual has extreme concerns about being exposed to possible scrutiny by others, and fears social or performance situation in which embarrassment may occur. In some instances, the fear may be quite defined, such as the fear of speaking or eating in public places, fear of using a public restroom, or fear of writing in the presence of others. In other cases, social phobia may involve general social situations, such as saying things or answering questions in a manner that would provoke laughter from others around them. A specific phobia is a fear of a specific object or situation that could cause harm, but the reaction to them is excessive and unreasonable and inappropriate. The phobic person may be no more anxious than anyone else until exposed to the phobic object or situation. Exposure to the phobic stimulus produces overwhelming symptoms of panic, including palpitations, sweating, dizziness, and difficulty breathing. These symptoms may occur in response to the individuals merely thinking about the phobic stimulus. Even though this disorder is relatively common among the general population, people seldom seek treatment unless the phobia interferes with the ability to function. Specific phobias have been classified according to the phobic stimulus. A list of some of the identified phobias can be found in Table 18.1 in your text, but note that the list does not include all possible phobias, as people can pretty much become phobic to just about any situation or any object. There are many theories on predisposing factors of phobias. Freud's classic theory associated phobias with the symbolic displacement of anxiety that was rooted in castration anxiety. And yes, I said castration. Modern day psychoanalysts believe in the same concept of phobic development, but believe that castration anxiety is not the sole source of phobias. They believe that other unconscious fears may also be expressed in a symbolic manner as phobias. Some theorists believe or think that fears are a conditioned response, that they are learned by imposing reward for certain behaviors. In instances of phobias, when an individual avoids the phobic object, he or she escapes fear, which is indeed a powerful reward. Phobias may also be acquired by direct listening or imitation, such as, "My mom's scared of snakes, so I'm afraid of snakes." Cognitive theorists believe that the anxiety is the product of faulty cognitions, or anxiety-inducing self-instructions. Two types of faulty thinking have been investigated: negative self-statements and irrational beliefs. Cognitive theorists believe that some individuals engage in negative and irrational thinking that produces anxiety reactions. The individual begins to seek out avoidance behaviors to prevent the anxiety reactions, and phobias result. Inborn fears represent a part of the overall characteristics or tendencies with which one is born that influence how he or she responds throughout life to specific situations. Inborn fears usually do not reach phobic intensity, but may have the capacity for such development if reinforced by events in later life, or later on in life even. Certain early experiences may set the stage for phobic reactions later in life. Some researchers believe that phobias, particularly specific phobias, are symbolic of original anxiety-producing objects or situations that have been repressed. A number of medical conditions have been associated with the development of anxiety symptoms. Some of these include cardiac conditions such as myocardial infarction, congestive heart failure, and mitral valve prolapse. Endocrine conditions such as hypoglycemia, hypo or hyperthyroidism, and pheochromocytoma. Respiratory conditions such as chronic obstructive pulmonary disease and hyperventilation, and neurological conditions such as a complex partial seizure, neoplasms, and encephalitis. Substance-induced anxiety disorders is only diagnosed if the anxiety symptoms are in excess of those usually associated with the intoxication or withdrawal syndrome. Substance-induced anxiety disorders may be associated with use of the following substances: alcohol, amphetamines, cocaine, hallucinogens, sedatives, hypnotics, anxiolytics, caffeine, cannabis, or other substances. Obsessive-compulsive disorders. The manifestation of obsessive-compulsive disorder, OCD, include the presence of obsessions, compulsions, or both, the severity of which is significant enough to cause distress or impairment in social, occupational, or other important areas of functioning. The individual recognizes that the behavior is excessive or unreasonable, but is compelled to complete the act. Common compulsions include hand-washing, ordering, checking, praying, counting, and repeating words silently. Obsessions are intrusive thoughts that are recurrent and stressful. Although they are recognized by the individual as irrational, they continue to be repetitive and cannot be ignored. Compulsions are repetitive ritualistic behaviors or mental acts that the individual feels driven to perform, which are intended to reduce the anxiety associated with the obsessive thoughts. All right, so I have a short video here. It's only about a minute long, if it can load here. There we go. It's 53 seconds long. From the movie As Good as It Gets. Very beginning. All right, so that's the end of that short video that we had there. As you can see, he had a multitude of different OCD habits, like locking the door, turning on the light switch, washing his hands and having to use so many bars of soap. And if you even paid attention, he was actually wearing gloves. Okay. All right. So bodily dysmorphic disorder. Bodily dysmorphic disorder is characterized by the belief that the body is deformed or defective in some specific way. The most common complaints involve imagined or slight flaws of the face or head, such as wrinkles or scars, the shape of the nose, excessive facial hair, and facial asymmetry. These beliefs are differentiated from delusions in that the individual with a body dysmorphic disorder is aware that their behaviors are exaggerated. In some cases, though, people with body dysmorphic disorder also develop psychotic disorders. People with body dysmorphic disorders often have other comorbid mental disorders, including major depressive disorder, anxiety disorder, and psychotic disorder. Hair pulling disorder. All right, so hair pulling disorder, or trichotillomania, say that 3 times fast, is defined as the recurrent pulling out of one's hair that results in hair loss. The impulse is preceded by an increased sense of tension and results in the sense of release or gratification from pulling out the hair. The most common sites for hair pulling are the scalp, eyebrows, and eyelashes, but may occur in any area of the body on which hair grows. Comorbid psychiatric disorders are common with hair pulling disorder. Some of these include mood disorders, eating disorders, anxiety disorders, substance abuse disorders, and personality disorders, most commonly histrionic, borderline, and obsessive compulsive. Hoarding. Hoarding disorder is defined as having persistent difficulty discarding or parting with possessions regardless of their actual value. Additionally, the diagnosis may be specific with the excessive need for continual acquiring of items. In previous editions of the DSM, hoarding was considered a symptom of OCD. However, now in the D5M or DSM-5, it has been reclassified as a diagnostic disorder. Individuals with the disorder collect items until virtually all surfaces within the home are covered. There may be only narrow pathways winding through the stacks of clutter in which to walk. Some individuals also hoard food and animals, keeping dozens or hundreds of pets, often in unsanitary conditions. So a good example of that is the picture here on your left. The severity of the symptoms, regardless of when they began, appears to become more severe with each decade of life. Associated symptoms include perfectionism, indecisiveness, anxiety, depression, distractibility, and difficulty planning and organizing tasks. In addition to OCD, hoarding is associated with high comorbidity for dependent, avoidant, schizotypal, and paranoid personality disorders. And if you pay attention enough, you can actually see there's a person sitting in the picture on the right amongst all the clutter. There are also many theories on predisposing factors of OCD and related disorders. Psychoanalytic theorists propose that individuals with OCD have weak, underdeveloped egos. The psychoanalytical concept views clients with OCD as having regressed to an earlier developmental stage of the infantile superego. Regression to the pre-Oedipal and anal sadistic phase, combined with the use of specific ego mechanisms, produces the clinical symptoms of obsessions and compulsions. Learning theorists explain obsessive-compulsive behavior as conditioned response to traumatic event. The traumatic event produces anxiety and discomfort, and the individual learns to prevent the anxiety and discomfort by avoiding the situation with which they are associated. This type of learning is called passive avoidance. When passive avoidance is not possible, the individual learns to engage in behaviors that provide relief from the anxiety and discomfort associated with a traumatic situation. The onset of pulling hair disorder can be related to stressful situations in more than 1/4 of cases. Additional factors that have been implicated include disturbances in mother-child relationship, fear of abandonment, and recent job loss. Studies also have shown a possible correlation between trichotillomania and body dysmorphic disorder and history of childhood abuse. Hair pulling disorder has commonly been associated with obsessive-compulsive disorders among first-degree relatives, leading researchers to conclude that the disorder has a possibility of hereditary or familial predisposition. Structural abnormalities in various areas of the brain, as well as alterations in the serotonin and endogenous opioid systems, have been noted. Genetics may also play a role in the development of hoarding disorder. Family and twin studies have indicated that approximately 50% of individuals who hoard report have a relative who also hoards. Recent findings suggest that neurobiological disturbances may play a role in the pathogenesis and maintenance of OCD. Abnormalities in various regions of the brain have been implicated in neurobiology of OCD. Electrophysiological studies, sleep electroencephalogram studies, and neuroendocrine studies have suggested that there are commonalities between depressive disorders and OCD. A number of studies have implicated that the neurotransmitter serotonin as influential in the etiology of obsessive-compulsive behaviors. Drugs that have been successful in alleviating the symptoms of OCD are clopramine and SSRIs, all of which are believed to block the neuronal reuptake of that serotonin, thereby potentiating serotoninergic activity in the central nervous system. I guess I forgot to change the slide for you guys. Alright, so now let's check your understanding. A newly admitted client diagnosed with OCD spends 1 hour packing and unpacking, folding and refolding personal belongings.
There is no special reason for this behavior. It relieves anxiety, it fosters organizational skills, it relieves meeting unfamiliar people in the day room, and it makes the client feel good. Correct answer here is A. OCD is characterized by recurrent thoughts or ideas, obsessions, that an individual is unable to put out of his or her mind, an action that an individual is unable to refrain from performing with a compulsion. This behavior directs the client away from underlying anxiety and focuses the client on repetitive activities such as packing, unpacking, folding, refolding, personal belongings. Alright, so next question. For the last year, a college student continually unrealistically worries about academic performance and love life performance. The student is irritable and suffers from severe insomnia. This behavior is associated with which diagnosis? Agoraphobia, GAD, social phobia disorder, or OCD? Question for here was B. GAD may be diagnosed with when excessive unrealistic worry and anxiety become chronic and last for at least 6 months. Anxiety experience is generalized rather than specific. Anxiety is not associated with specific objects like phobia or events as in PTSD. Nursing diagnosis commonly associated with anxiety, OCD, and related disorders. Panic anxiety, stress-driven GAD, are common there. Powerlessness, anxiety and GAD. Fear, again phobias, and social isolation, agoraphobia. Ineffective coping for OCD, ineffective role play for OCD, it's the body image or body dysmorphic disorder, and ineffective impulse control for fear pulling disorder. The following criteria may be used for measurement of outcomes in the care of a client with anxiety disorder. To make sure you're able to recognize signs of escalating anxiety and intervene before they reach panic level. Panic and generalized anxiety disorder occur to victims, and make sure you're able to maintain anxiety at a manageable level and make independent decisions about life situations. That one's commonly used for panic and generalized anxiety disorders. Functions adaptively in the presence of a phobic object or situation without experiencing panic and anxiety. That's a phobic disorder. Verbalizes a future plan of action for responding in the presence of phobic objects or situation without developing panic and anxiety. Again, phobic disorder. Able to maintain anxiety at a manageable level without resorting to the use of ritualistic behaviors, OCD. Demonstrate more adaptive coping strategies for dealing with anxiety than ritualistic behaviors, again, OCD. Verbalize a realistic perception of figures or appearance and expresses feelings that reflect the positive body image. That would be body dysmorphic disorder. Verbalize and demonstrate more adaptive strategies for coping with stress situations. That's trichotillomania, which is that whiffling. Alright, so let's review the training implementation stages of nursing practice for clients with anxiety, obsessive compulsive, and related disorders. Anxiety is again defined as a vague, uneasy feeling of discomfort or dread accompanied by an autonomic response. The source is often non-specific or unknown to the individual. It's a feeling of apprehension caused by anticipation of danger. It is an alerting signal that warns of impending danger and enables the individual to take measures to deal with the threat. Goals for treatment could include helping the client verbalize ways to intervene in escalating anxiety and helping the client recognize symptoms of anxiety. Interventions could include not leaving the client alone when experiencing panic, using simple words and brief messages, exploring the possible reasons for anxiety and panic. Fear is defined as the response to the perceived threat that is consciously recognized as dangerous. The goals for treatment could be to help the client discuss the phobic objects or situations and to help the client be able to function in the presence of the object. Interventions include exploring the client's perception of the threat and helping the client explore underlying feelings that may be contributed to irrational fears. Ineffective coping is defined as the inability to form a valid appraisal of the stressor, inadequate choices of practical responses, and/or inability to use available resources. Goals could include helping the client decrease participation in ritualistic behavior and to help the client demonstrate the ability to cope effectively without resorting to obsessive compulsive behavior or increasing dependency. Interventions could include working with the client to determine the types of situations that increase anxiety resulting in ritualistic behavior and learn ways of interrupting obsessive thoughts and ritualistic behaviors. The body image defined as confusion and mental picture of one's physical self. Goals include helping the client understand that changes in the bodily structure or function are exaggerated out of proportion to change that actually exists. Individuals should include assessing the client's perception of their image, helping them see that their perception is distorted, and involving the client in activities to reinforce a positive sense of self. Ineffective impulse control is defined as a pattern of performing rapid, unplanned reactions to internal or external stimuli without regard for the negative consequences of these reactions to the impulsive individual or to others. Goals should include helping the client cope with stress by means other than pulling out their own hair and eventually discontinuing the behavior. Interventions include supporting the client in efforts, assisting with habit reversal training, and offering support when setbacks occur. Let's check your understanding. In terms of client who's experienced a panic attack, which of the following nursing actions should be implemented? Leave your client alone to maintain privacy, discuss with the client regarding unit rules and regulations, sit with the client in the day room to provide comfort, or communicate with simple words and brief messages. Questions for her is D. When communicating with a client experiencing panic attacks, the nurse needs to use simple words and brief messages, spoken calmly and clearly. Any communication that is loud and commanding would only escalate that anxiety. Client and family education for clients with anxiety, obsessive compulsive, and related disorders. Topics for discussion with client and family include the nature of the illness, including the causes of anxiety or OCD, the symptoms of the disorder, management of the illness, including appropriate medication management and stress management, and support services, including crisis hotline and support group information. Management of the illness, medication management. Look for possible adverse effects. Let them know the length of time for it to take effect and what to expect from the medication. Same things that your instructors have you tell them all the time in clinical. Stress management. Teach clients and families ways to interrupt escalated anxiety and relaxation techniques. Tell them about support services and provide them with brochures and contact information. Better yet, call and set up the first appointment for them. Crisis hotlines, support groups, and individual psychotherapy are all other things that you should know for your area. And the final step of the nursing process, the reassessment is conducted to determine if the nursing actions have been successful in achieving the objectives of care. So then the whole nursing process will start all over again. There are various treatment possibilities for clients with anxiety, obsessive compulsive, and related disorders. Therapy can be beneficial to clients suffering from bipolar disorder. Supportive psychotherapy is designed to help the client identify their personal strengths and explore adaptive coping mechanisms. Insight-oriented psychotherapy, which is rooted in Freudian psychology, is designed to help a client identify, explore, and resolve internal psychological conflicts that are contributing to anxiety. Cognitive therapy strives to assist the individual to reduce anxiety responses by altering cognitive distortions. Anxiety is described as being the result of exaggerated automatic thinking. Cognitive therapy for anxiety is brief and time limited, usually lasting from 5 to 20 seconds. Brief therapy discourages the client's dependency on a therapist, which is prevalent in anxiety disorders, and encourages the client to be self-sufficient.
modification has been used to treat trichotillomania. Various techniques have been tried, including covert desensitization, habit reversal therapy, which is also known as HRT. These may include a system of positive and negative reinforcements in an effort to modify the hair pulling behaviors. With HRT, in an attempt to extinguish the unwanted behavior, the individual learns to become more aware of the hair pulling, identifying times of occurrence, and substitute a more adaptive coping strategy. And then other forms of behavior therapy include systematic desensitization and implosion therapy or flooding. In systematic desensitization, the client is gradually exposed to the phobic stimulus, either in real or imagined situation. In the implosion therapy, the therapist floods the client with information concerning the situations that trigger anxiety in him or her. The therapist describes the anxiety-provoking situation in a vivid detail and is guided by the client's response. The more anxiety provoked, the more expedient is the therapeutic endeavor. Anti-anxiety drugs were historically referred to as minor tranquilizers. Anxiety agents are used in the treatment of anxiety disorders, anxiety symptoms, acute alcohol withdrawal, skeletal muscle spasms, convulsive disorders, status epilepticus, and preoperational sedation. And here there's a whole list of some of the anti-anxieties. Now just remember that for the most part, as you can see, Pam has a lamb. All right. Benzodiazepines have been used with success in treatment of generalized anxiety disorder. They can be prescribed on an as-needs basis when the client is feeling particularly anxious, like alprazolam, lorazepam, clonazepam. They've all been particularly effective in the treatment of panic disorder. Several antidepressants are effective as major anti-anxiety agents. The tricyclics, clopramine and empramine, have been used with success in clients with experiencing panic disorder. However, since the advent of SSRIs, tricyclics are less widely used because of their tendency to produce more severe side effects at the high doses required to relieve symptoms of panic disorder. Several studies have called attention to the effectiveness of beta blockers like propranolol and alpha-2 receptor agonists like clonidine and amelioration of anxiety symptoms. Nope, sorry, I forgot to change the slide again for you. I'm going to leave it here for a few seconds. Okay. The SSRIs, fluoxetine, paroxetine, sertraline, and fluoxetine have been approved by the FDA for the treatment of OCD. The tricyclic antidepressant clopramine was first drug approved by the FDA in the treatment of OCD. Clopramine is more selective for serotonin reuptake than any other tricyclics. Its efficacy in the treatment of OCD is well established, although the adverse effects, such as those associated with tricyclics, may make it less desirable than SSRIs. The most positive result of pharmacological therapy with body dysmorphic disorders have been with clopramine and fluoxetine. These medications have been shown to reduce the symptoms in more than 50% of clients with the disorder. Various psychopharmacological agents, including chlorpromazine and amitriptyline and lithium carbonate, have been tried in the treatment of trichotillomania with moderate results. Recent success with SSRIs, augmented with pimozide, has also been reported. One recent study showed the olanzapine to be safe and effective treatment for trichotillomania. All right, let's check your understanding one more time. What should the nurse do to teach a client who is taking alprazolam or Xanax 3 times a day that there is a potential for dependence and tolerance, the importance of discontinuing Xanax immediately if addiction is suspected, that increased caffeine consumption can enhance the effectiveness of Xanax, or that Xanax is not habit forming? All right, the correct answer here was answer A. Xanax is a benzodiazepine and is a addictive properties. It is the responsibility of the nurse to teach the client about dependence, tolerance, and other signs and symptoms of addiction. And that's it for this PowerPoint slide.